بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا المرسلين سيدنا محمد صلى الله عليه وسلم وعلى آله وصحبه وسلم أجمعين. Today I'm going to take another example for radiological procedure, which is pulmonary embolism. So, what's pulmonary embolism? Pulmonary embolism is an examination for the lung to detect if there is any embolization inside the pulmonary artery branches or not. So, indications: patient with clinical suspicious of pulmonary embolism. These clinical indications, so it's not our business really, but clinicians are sending a patient because of possibility of pulmonary embolism. Contraindications: actually there is no contraindication. There is no absolute contraindication for pulmonary embolism examination. Why? Because this is top emergency radiological procedure, so we have to do it once it's indicated. The only contraindication, the only absolute contraindication is previous anaphylactic reaction to the contrast media. Otherwise, no contraindications. Okay, even if the patient is pregnant, we have to do preparation. Extra-hospital preparation: there is no extra-hospital preparation except for study of renal function test. In most centers, they are requesting serum creatinine level, which should be below 1.5 milligram. Some centers request glomerular filtration rate, which is more specific. Okay. Intra-hospital preparation: no preparation except for just fasting for 3 hours or 4 hours. Intra-departmental preparation: insertion of intravenous cannula, which should be, it's better to be in the antecubital region, and should be big caliber, so 16 gauge or 18 gauge at maximum. Intra-room preparation: no intra-room preparation. Okay, so how to do the procedure? Patient is lying supine in the CT scan, and then we are using one of the two techniques. The first technique is test bolus examination, and the other technique is bolus tracking. In test bolus, we are giving a small amount of contrast media and doing repeated cuts of the pulmonary artery and measuring when maximum contrast opacification of the pulmonary artery happens, and this will be the best timing for radiological radiological study. So we are adjusting the machine to start after this at this timing post injection. This is bolus tracking. And the other technique is this first technique is test bolus. The other technique is bolus tracking. Bolus tracking, we are putting a marker at the pulmonary artery trunk and measuring how when the contrast reaches the pulmonary artery, and then ask the machine to start immediately after good opacification of the pulmonary artery. The best timing by any of the two procedures, the best timing to do the examination is when the contrast leaves superior vena cava and enters the pulmonary circulation, and before it leaves the pulmonary circulation into the left side of the heart. So this needs some experience to adjust the contrast media to reach and start the examination immediately at this timing. And the dose of contrast media also should be adjusted not too much, because we need the contrast media only in the pulmonary circulation, not in the superior vena cava and not in the left side of the heart. Okay, so 30 to 40 ml of contrast media are quite sufficient with the new machines to do the procedure. 100 ml of contrast media is too much, and I saw many centers doing the procedures. They finish the examination and the injector is still injecting the contrast media after finishing the procedure. So this is waste of contrast media and burden to the kidney and burden over the patient. Okay, so remember, the best timing for starting radiological examination of pulmonary embolism is when the contrast leaves the sphere vena cava and when the contrast ends in the pulmonary circulation and doesn't reach the left side of the heart. We use either one of the two techniques, either bolus tracking or test bolus, and to adjust this timing. Okay. Then there is no focus field medicine because this is CT scan and also central beam, and the dose is adjusted mechanically or electronically by the machine. So assessment of the study, as I said before, when the contrast leaves the superior vena cava, because the contrast in superior vena cava are very dense. It's very dense and it casts a lot of artifacts. So we have to wait until the contrast leaves the superior vena cava and in the pulmonary circulation, and also before the contrast leaves the pulmonary circulation into the left side of the heart. This is how to assess the quality of the film. And usually we start the study in a codocranial direction. We start at from the bottom of the lungs down up to the apex of the lung, not the reverse. And most of centers are doing this. Post-procedure care, no post-procedure care, just examine the patient for any possibility of contrast hazards or contrast reaction, and ask the patient to take care of the possibility of delayed contrast reaction, and also to take care of the antecubital cannula. Okay, so this is finished about the pulmonary embolism. I hope it will be beneficial for all. Thank you very much.